it's a great question, and thanks for asking it. There are a lot of different ways that patients can be managed after an LVAD, left ventricular assist device implantation, but there's no consensus across the board. We all think that we know best practices, standard of care, but no one has studied them, rigorously or comprehensively in a clinical trial. So we use the three components that we believe are important for the RV in terms of helping blood flow go from the right side of the heart to the left side of the heart, because the left side is the only one that is actually being, assisted with the device. So we want to decrease afterload. And we do that with inhaled nitric oxide. We do that by lowering the preload, which is assessed by a wedge pressure on the left side of the heart. We also want to make sure that the preload of the RV is not too high, and that's done with diuretics, lowering the pressure on the right side of the heart. And then we want to make sure that the RV has some contractility. As we know, when an LVAD goes in, it changes the geometry of the septum of the heart and all of the ways in which the right side of the heart usually contracts. So usually we use inotropes. We in our institution, usually use dobutamine. So preload, afterload, and contractility. We use a few other things in our algorithm just to, best practices. We want to try and maintain normal sinus rhythm. We want to, increase the heart rate because we know heart rate times stroke volume is cardiac output. So we want to improve the cardiac output of the right side of the heart. And then in the beginning, when they're currently ventilated after the surgery, we want to make sure that we have, the ventilatory management, decreasing the PEEP, decreasing the afterload, kind of improving oxygenation and decreasing respiratory acidosis. As our primary outcome, we wanted to assess the HRAEs, hemocompatibility related adverse events, but we also wanted to incorporate, a new paradigm that we know about, but had not yet been coined, which is hemodynamic related events, looking at RV failure and aortic insufficiency. So a total of all the different components of what could potentially go wrong after an LVAD. And at 24 weeks with the RV protection strategy, we saw a significant difference, 80% versus 40%, survival free from HCREs and HREs in the RV protection strategy. I think most notably, although not powered for it, was the signal for RV failure. This was assessed by both INTERMACS and the ARC criteria looking at severe RV failure. And we know that in the RV protection strategy, no patients had severe RV failure, whereas in the usual care arm, three did. And they were quite significant, including death, significant inotrope use, or RVAD within the first 30 days. This is a study that I think is a pilot study, but again, a very important first step to seeing can a comprehensive strategy actually improve outcomes. And while it being a pilot study, we looked at patients that were not at severe or heightened risk of RV failure. So we didn't have INTERMACS 1 or 2 patients. But interestingly, even patients where we thought did not have a high risk of RV failure, we still saw that 30% in the usual strategy actually did end up having RV failure. So this is a clinical trial that we know now can impact patients, all patients that are getting LVADs and try and protect the RVs. Whether it's, will protect the RV with much higher risk patients is yet to be seen, and that's where we need more studies to kind of see it in all patients. But this is a study that takes physiologic principles and applies it to our patients in an algorithmic fashion, where in a multidisciplinary field where we have cardiothoracic surgery, anesthesia, heart failure attendings, everyone is taking care of these patients, everyone can look at this algorithm and say, okay, are we following the, physiologic principles that we believe will protect the RV from failing after an LVAD? Great question. That brings me back to the kind of Intermax 1 and 2. So being a pilot study, only 20 patients, we did not want to lose a signal. You know, if you have very high risk patients, you can end up having RV failure despite best practices. So with the patients not being Intermax 1 or 2, yeah, we know that, you know, we had this. We had this positive trial for patients that were on inotropes or coming in with decompensated heart failure, multiple heart failure admissions. But these were not patients that we presumed would need an RVAD up front, for example, that had severe RV failure. So for our high risk patients, we have to keep that in mind. Not to say that we can't apply these best principles to those patients, but knowing that we can't assume that all of those patients are going to have, full protection of their RV despite everything that we're trying to do.